Hello. Today, I'll be demonstrating the evidence-based for inserting a nasogastric tube, or NGT. This procedure is commonly performed for feeding, medication administration, or gastric decompression. Let's begin. First, I confirm the indication for NGT insertion and check for any contraindications, such as facial trauma or suspected basal skull fracture. I explain the procedure to the patient and obtain informed consent. Next, I gather all necessary equipment. The correct size, radio-opaque nasogastric tube, with external centimeter markings. Water-soluble lubricant. Gloves, and personal protective equipment. A 50 ml syringe. pH indicator strips. Adhesive tape. A glass of water with a straw, if the patient can swallow. A receiver or kidney dish, for potential gastric aspirate. Measuring the tube. To determine the correct insertion length, I use the most up-to-date, evidence-based method, the corrected Konex method. I measure from the tip of the nose to the earlobe, then to the xiphoid process, and apply the Konex formula. Konex length equals the NEX measurement, multiplied by 0.38696, plus 30.37, plus 6 centimeters. I mark this length on the tube, with a piece of tape or marker. Patient positioning. I position the patient, sitting upright, at a 45-degree angle, to reduce the risk of aspiration and facilitate tube passage. Inserting the tube. I wash my hands and put on gloves. I lubricate the tip of the tube with water-soluble lubricant. I gently insert the tube into the most patent nostril, directing it along the floor of the nasal passage. Once the tube reaches the oropharynx, I ask the patient to lower their chin, and if safe, to sip water and swallow. With each swallow, I advance the tube smoothly to the pre-measured mark. Confirming placement. To confirm placement of nasogastric tube, I first attempt to aspirate gastric contents with the syringe. I test the aspirate with pH strips. If the pH is between 1.0 and 5.5, this strongly suggests correct gastric placement. If I cannot obtain aspirate, or the pH is above 5.5, I arrange for a chest or abdominal X-ray to confirm the tube tip is below the diaphragm and in the stomach. I do not use the tube for feeding or medication until correct placement is confirmed and documented. Securing the tube. Once placement is confirmed, I secure the tube to the nose with adhesive tape, ensuring the external centimeter marking is visible at the nostril. I check that the patient is comfortable and able to breathe easily. Documentation. I document the procedure in the patient's record, including the insertion length, method of confirmation, the external marking at the nostril, and the patient's tolerance of the procedure. Ongoing care. Before each use, I check the external tube marking, and, if indicated, retest the aspirate pH to confirm ongoing correct placement. I monitor for signs of respiratory distress or tube displacement, and regularly inspect the nostril and oropharynx for pressure injury.